Good morning. I am a gynecologist. I can deliver babies, but I don't anymore. My point of departure for this presentation is a study that wasn't intended as one study that would be presented in the paper. I happened to go to the little country in West Africa called the Gambia in the beginning of the 1990s. Because I wanted to study a specific phenomenon in reproductive health. And I remained studying reproductive health in the Gambia for 23 years. And growing old like I am now, I'm getting like quite old, not retired, but quite old. It gives you a possibility to reflect about what has happened over all these years. You have been there. So you said that anthropology takes time. Well, being in the Gambia for 23 years is quite a substantial fieldwork. When I came to the Gambia, my point of departure was there was this Cairo bus. I was both an actor at the global level. I got to be in the Cairo conference as a Norwegian delegate. I got to work with the World Health Organization as a policymaker in the research program on reproductive health, but I also got to be a participant in the development of local healthcare issues, politics, programs and systems at the ground level in the Gambia. And this leveling of what happens at the global level, what are these discourses, and what happens at the local level is what fed this paper. I'm not going to give you any text. I'll just show you some pictures of the Gambia so that we are in the Gambia when I'm talking. When I came there, as I said, it was the bus of the Cairo conference. It was just before, during, and after the Cairo conference. And there was lots of discussions around reproductive health in the Gambia. One of the reasons that I was invited there is that they wanted to broaden the scope of understanding reproductive health. So I was there to do the first ever fieldwork in Africa by a foreign scientist on infertility, absolutely off topic in the reproductive health agenda. High fertility is the issue in Africa. Infertility was not an issue. But we managed to do the studies, and it was quite interesting. I would say that my understanding of what has happened in the Gambia over these 2 decades or so, I have tried to divide it in 4 to 5 epochs of development. When I came there, it was towards the end of the first epoch, the post-colonial, Gambia came out of colonialism, epoch of primary healthcare and Alma Ata ideologies. I found a country that had created a health system that was built upon the ideologies of primary healthcare, and they had a very systematized approach to it. Not decentralized, not taken in as a separate, where people could interact at the local level, but they had a plan for how the healthcare map and the health system should look in the Gambia. And they were very concerned, as of an ideology after colonialism, that everybody should have something where they live. And they managed to build a health system where every village in the Gambia was either a designated primary healthcare village or not. And they had a system of all sorts of healthcare providers at the local level that did the basics. Everybody was covered with the basics. And I think that was a very unique and a sustainable system because it democratized healthcare delivery. It had the ideology that everybody should have something for all, and more for those in need. The system is still there, so it must have been a good system. They haven't abandoned it, but there have been challenges. Then during or just after the primary healthcare era came the buzz of Cairo and Beijing that raised issues of women's health, women's participation, women's development, women in development. There was large women in development projects that looked at infant feeding, maternal health, maternal waiting homes, building a lot of social structures for women, not so much in the healthcare system as such, but the momentum for raising the issues of women's health was absolutely there. But somehow it was not followed up with the same type of funding that we would need to implement. So whilst the Cairo and Beijing bus lasted for a little while, very soon came in the World Bank. You remember that in the 1993, the annual report of the World Bank was called Investment in Health. And it was really economic investing in health. It introduced the economics of healthcare to a very large extent, something that hadn't been there that much before. The implications of the World Bank buzz on investment in health in the Gambia was, yes, investment. They started to build structures. They built structures out of concrete and iron, and they built health institutions. Unfortunately, some of these construction and institution buildings also carried with it substantial corruption. They also introduced user fees, which is part of the investment in health that you should pay for healthcare. The Gambia wasn't a country that attracted a lot of private healthcare. It was still the government system, but it became much more of a system in which you had to pay for what you wanted to have. During the second part of the World Bank era in the Gambia started the MDG discussions. And the MDG discussions, the Millennium Development Goals 4 and 5 were there in the Gambia, but they were there a little bit aside of the rest. There was attention to it, there were people concerned with it, there were people asking for it, but again, there was no funding. So the people who work on the ground in the Gambia, they work a lot with women's health because they do antenatal care. They have good indicators when we talk about indicators. Gambia has good indicators for antenatal care coverage. They have relatively poor indicators for institutional deliveries. And they haven't abandoned the traditional birth attendants because they don't have anyone to replace them. If you abandon the traditional birth attendants in the Gambia, then where should the women deliver? There are not enough health workers. And that's where we are still today. That was the situation in 1994 when I came in. That was the situation before I got there for the first time. And it's the situation today. Then we ventured on to the era of the Global Fund and Gavi, targeted interventions. And these interventions, in the Gambia as in other countries, they funded programs, specific, targeted, vertical programs within the health sector. When I talked to some of my friends in the Gambia during that Global Fund era, they said, look at our friends who work in tuberculosis and malaria. They have land cruisers, four-wheel drives, computers. They have large conferences. They get to go to meetings elsewhere. They have to do a lot of reporting, but they have new offices with aircon. And we, in maternal health, we have bicycles and pencils still. It was really, really evident that the previous equitable healthcare system that was there now got fragmented, that you had some diseases and some problems. They were serious diseases and problems, absolutely. But they were more funded, well funded than the others. And it was very, very visible. Those programs do work, but the rest of the health system continues to stumble around trying to solve problems. And Gambia is one of the relatively poor countries in the world where the health indicators, the maternal mortality and newborn mortality is still pretty high, like we've heard throughout the conference, that Africa lags behind, and it still lags behind. I started to work on maternal health during this period. I finished with infertility, and I started to work with local people on trying to document the situation in maternal health. We did all the work we did with local partners, and they were the ones that implemented the studies that we did. But we did studies only on maternal and newborn health. And we documented the situation in the health system of not having the capacity to do what they were supposed to do. The quality of care for maternal health in the Gambia during the past 5 to 10 years has been suboptimal. Lack of blood banks, lack of antibiotics. Though you deliver in a healthcare system or in a healthcare institutions, night shifts and weekends, the person delivering babies is the cleaner, even within the healthcare structure, in some of the places. There are pockets of very good care. There are dedicated people that manage the system. There are also places where nothing functions well. There are also transport problems. When the rainy season starts, it's difficult to pass the roads, and you can't even get over the river. Another thing that has happened in the Gambia is that there has been political turmoil. Gambia has had a coup, and they have had attempts of counter-coups. They have a president who is nearer to God than I am. And that also has implications for the running of health services. And a lot of people who work in the health sector that were very vocal, very active in the Alma-Ata area have now silenced and become quiet, because it's dangerous to be critical to the system in the Gambia, because then you're removed. And one of my students who did his master on maternal mortality, he did his doctoral studies in Norway on maternal morbidity. He returned to the Gambia as the only one. He's a nurse midwife. He's a man with nurse midwifery. Probably in Norway he would have been a doctor, but he returned as one of the few who had a PhD on maternal health, and he became the director of health services. Just right out of Oslo University, PhD, director of health services. And he did very well, but he was critical. He was very critical to what happened in the country. And after some time, he was removed because he was too critical for the system itself. And that happens to a lot of people. They are moved around in the system, and that creates a system that's very vulnerable because of turnover and because of lack of continuity. Another thing that's happened in the Gambia is that there has, because of the political complications of the country and the critics that people have come up with to the government, is that there is an absolute absence of bilateral donors. Now, with bilateral donors, you can negotiate funding for specific things that you want to do that are outside of the big actors like the Global Fund and World Bank. Those people aren't there in the Gambia, so now there's nobody who funds maternal health except the government itself and a little bit from UNFPA. So there is a constant lack of funding or opportunity for maternal and child health services, though the services are there. Development, there is progress, as all over the world, but the development is very slow. A few years ago, user fees for MCH were removed, but nobody told the recipients of the user fees what they should replace those resources with. There was no mechanism to give the health workers the same type of payment from another source when the user fees were removed. So we don't know really how things are going to go in the health sector. This has, of course, led to, as in very many countries, that where people are underpaid, that they have to take their payments unofficially. There's not that much of it, but it exists. Gambia has also had a very good health sector policy that they have developed recently. There is a good policy for the health sector. I have read it. It's very comprehensive. It's very well thought through. But unfortunately, it is not implemented because implementation costs money and demands healthcare workers. And as in many, many other countries in sub-Saharan Africa, there is a major health manpower crisis. I go to the Gambia again and again, and I monitor what is happening. I talk to people. I look if there is there are things happening. We have supported a few activities that they have liked, like we have had two rather large conferences. And one of the things that they have been grateful about is that we have come there and made it a little, given space for local actors to discuss issues among themselves within this framework of evidence and science and politics. There have been no major fora for these types of discussions in the country, and I think those things are so important when we talk about development. Develop local resources, local critical people who have the ability to examine the things that come from above and implement them in the country, and to set the agenda for themselves in local discourses and local fora. I think that's all. Thank you.